Okay.
Yes, you can start now.
Okay, lovely. Thank you so much for inviting me to this conference. I'm sorry you can't see me running around as you normally do and jumping up and down. This is a little bit more controlled. So I have put my talk in two parts. And the first one is the basis of physiotherapy and rehabilitation in adults and children. And everything I say about children, apart from them growing, will be the same as adults. So for adults, for exercise, for activity, for the basics, then it applies to adults as well as children. So what we will talk about is, why is physiotherapy important? What doctors and patients should consider in a physiotherapy rehabilitation process? What is a must in physiotherapy? Is there a difference in patients on treatment to those not on treatments? But first we need to start to discuss what are the problems. So the role of the physiotherapist. What does a physiotherapist do? First, we assess using the appropriate scales and tests. Many physiotherapists assess merely using their eyes. But you also have to have an understanding of spinal muscular atrophy, the patterns of weakness, and the problems that will be encountered in the future. Because much of what we're trying to do is prevent problems. It is easier to prevent them than to manage them. So once we have assessed, and if we're using our eyes, we're assessing the whole time. We treat adults, children's, babies on what we learn from this, and we need to make a plan of what is most important, not just for us, the physiotherapist, but also for the patient and family. We must teach the parents, the carers, and others, maybe in school, maybe in the workplace, to manage physiotherapy programs. We must reassess regularly. We must see where the changes are. We need to make adjustments to programs. We need to think whether something that we have suggested in the past is working or not working. We need to continuously reassess what is happening. So if you work with an adult or child on a regular basis, even every week, you must think, is what I did last week useful and effective? And also to research or to contribute to research programs and population databases. And that is also part of the physiotherapy job, to help to understand not only SMA as it was, but very much more now, SMA with new treatments. And this is very hard, not only because there are 3 treatments that children or adults may be getting, but they are getting them at different stages of the disease. They have different amounts of weakness and contractures when they start these treatments. And so progress is almost different in every person you see. The physiotherapy is important because if it wasn't, we wouldn't be working in SMA. And the ideal behind physiotherapy is to achieve maximum possible function, the best that person can do based on their physical status. and helping them and their parents or partners or carers to reduce the negative effects of disease, promoting activity, and that can just be being independent, exercise because it's important for all of us, mobility because we need to move around. Human beings are moving creatures, and overall, the idea of physiotherapy is to improve the quality of life. And if we are not doing that, then we are not doing a good job. So what are these negative effects of SMA? The primary problem is weakness. It leads to reduced function, and that can include speech and respiratory function. It leads to reduced mobility, and it is natural for humans to want to move from place to place. And not only is it natural, it is essential for survival. Weakness leads to contractures, which we all know so much about, but it never hurts to hear it again. Weakness leads to scoliosis, breathing problems, and in SMA, there is noticeable fatigue. So we need to look at the different types of SMA and not treat them by category, type 1, type 2, type 3, or non-sitters. We need to treat them by difficulty. So we have a big group of children, particularly now with treatments, who are weak non-sitters. And when we say non-sitter, we mean a child who cannot sit independently, but needs support. That does not mean they cannot sit in appropriate seating. And in the weak non-sitters and even stronger non-sitters are those children and adults with type 2 SMA who are no longer able to sit independently. So that what we are getting is a certain group of people who cannot sit unless they are being held in some way. The stronger non-sitters, many of them, particularly with type 1, and some of the weaker type 2, are gaining the ability to sit with new treatments. And while they can sit, their spines are still not strong, and they are still subject to quite marked scoliosis. The weak sitters have many of the same problems as the stronger non-sitters. With all these three first groups, respiratory function is the main concern, and any other type of physiotherapy or management has to come second. The intermediate sitters are now a very, very big group, and they include many of the stronger type 1s on treatment. And they range from those who sit well to those who can crawl on the stronger side of sitting. We have type 2s who can now stand or were standing. They can be stood. They can be put into independent standing. Not as many can get themselves into the standing position. So many of these strong sitters and crawlers can be put into standing but cannot get there. And then we have the weak walkers. The weak type 3s who without treatments will definitely not continue to walk. Some of the better type 2s who are walking, but on treatments we cannot be 100% sure they will continue to walk into adulthood. We have the weaker walkers who may lose ambulation, the intermediate walkers who may lose ambulation when they get older, particularly around puberty, when they grow fast, and the stronger walkers, some of whom would have been intermediate walkers with treatments, who will continue to walk into adulthood. But many of the walkers can still get scoliosis, particularly if they lose ambulation before puberty, and even walking type 3s can get scoliosis. So the priorities of those non-sitters and the weaker sitters are respiratory, spinal posture and scoliosis, contractures, pain, and movement and mobility. The sitters, their priorities are very similar. Some of the stronger non-sitters may achieve some independent ambulation with treatments, but are still at risk of problems. We need to look at the child and not necessarily where they were before treatments, if they are on treatments, and if they are not on treatments, and this is so important, we need to consider that if treatments come for those people not on treatment now, the more contractures, the more they get weak, the harder it will be for treatments to be effective. And I will say this continuously because it is still important for children not on treatments to have physiotherapy to maintain good joint range and power as possible. So in walking children, we need to try and keep walking. It is helpful for the spine. It is helpful for the joints. It is helpful if they can move around into places, particularly in countries where parts of the country are not wheelchair accessible. But walkers still get all these problems, and they are some of the most important children to treat. Because while we know the type 1s have major respiratory difficulties, and that is their priority, keeping the type 3s and better type 2s ambulant if we can is very important for their body and their soul. They want to continue, many of them. We know that in type 3, many of the weaker children only achieve a few steps by themselves. They will walk they will use a wheelchair from an early age and possibly even lose the ability to stand to transfer. And that is mainly through weakness, height, and contractures. The intermediate group walk functionally for longer, but will often use a wheelchair for longer distances. They struggle with stairs, getting up from the floor, and we forget that going in the street is very difficult when the ground is not flat, when there are steps up and down from the road, where there are holes in the pavement. In countries like the UK, you would think it is better, but it is not always better for people walking in the street. And we also forget the effects of weather. If you struggle to walk well, then walking on a pavement of snow or ice is impossible. So in a cold country or a cold season, getting outside is impossible without a wheelchair. And that is true even of some of the stronger type 3s. So a wheelchair, while they may think they do not need one, they must think about the whole of life, the whole of the year, every situation they may want to encounter. But to make physiotherapy manageable, it should be part of life, not an extra. If it is part of every day, then it will be much easier. Because we need to remember, as physiotherapists, we are not so important in the person's life. We are a small, small part of it. There are many, many other people who are in that child's life only because they have SMA. So you will have maybe an occupational therapist, a speech therapist, a dietitian, many different doctors, one looking after respiratory, after endocrine, after the spine, after the hips. Lots of different people are involved with that child. So we have to make physiotherapy manageable. We also have to consider that no situation is the same. We may have two type 2 children who look very similar, but their family situations will be different. So we do not give out programs for a type 2. We give out programs for that particular type 2 who may have 3 or 4 brothers and sisters, who may have another brother or sister with SMA, who may only have one parent at home, who may have a brother or sister with a different difficulty. No two children and families are the same, and physiotherapy needs to understand that and work on the individual basis. So one of the things that we talk about are treatments changing the type. But this becomes confusing. If you were type 1 and have had treatment and now sit, are you type 2? And within the medical world, we try not to confuse the types. So we will talk about a sitting type 1 or a walking type 2. In the same way that when a type 3 lost the ability to walk, we did not then call them type 2. We called them a non-ambulant 3 and still do. So you have a sitting type 1 or a walking type 2, and in some cases, particularly in very early pre-symptomatic children, you may have a walking type 1. It is not common. Do not think that many type 1 children who presented with symptoms will walk. Most of the children who are walking were treated pre-symptomatically. Is there a difference between those on treatment and those not on treatment? The problem that we have, as I said, is that every child on treatment looks different. We do not know as much about adults, but we do know that if you are very contracted, if you have been in a wheelchair for many years, then treatments are not suddenly going to stand you up and make you walk. So every person has to work with their therapist to develop those things that have improved. And many of the adults feel that obviously their improvement is in their arms, in their trunk, in their head. Some children say that some of the best improvement is in their speech, not in their body, that they can talk louder, that they can talk more clearly. something that a physiotherapist cannot effect. The children with type 1 are now, even at our hospital, in the days before treatment, we would maybe have 6 or 7 surviving children. We now see nearly 40 surviving SMA1 children. We have 8, 9 and 10-year-olds, and they are only going to get older. But we are seeing many problems we never saw before. Because the children did not survive, we did not see them with severe contractures, with severe scoliosis, with speech and communication problems. And some are even showing learning difficulties, inasmuch as their intellectual development is not progressing with their age. So we are seeing new changes in a much, much bigger group of children we have never known until now. This little boy was born with torticollis, with his neck in this position. We have had 2 type 1s from our children who have had this torticollis from birth. One is much better. This young man, as you can see from his x-ray, is still very severe. He is held well in a good spinal jacket. This to this is a big improvement in a good spinal jacket, but it needs to be good. But unfortunately, we have not corrected his neck fully, and it may be that spinal surgery will also have to work for his neck, which will limit his head movement, we know. This is our other young man who has torticollis. His problem is not so much scoliosis as kyphosis. And this is the problem he has. His neck is now much better. He is standing. He has now got caphos, which he likes wearing and wants to try walking. But this is his spine. Kyphosis, if it is treated young and early, can be preventable, but it does mean early treatment and management, and the physiotherapist must get involved from the beginning with intensive treatment. The other problem that we are seeing in these children is severe hip tightness. We have children who can lift their legs right up in the air, that looks incredibly strong, but unfortunately it does mean the muscles at the front of the legs here are very tight, and the sides of the legs pull them apart, the iliotibial band, and these are the sorts of problems we are seeing in many of our children. They cannot lie flat, they can be sat, but there were many, many problems trying to stand them. We have dislocated hips, we have dysplasia. Some of them are causing pain. But we have no national or international consensus on how we manage these hips, because this is a new problem. If you look at standards of care, you will see that standards of care will say, do not do hip surgery in SMA. We cannot keep that going. We need to think about how we can manage these hips. But like with all surgery, you cannot just cut and expect things to change. Surgery cures nothing. And therefore the problems are still there. And that is not true of spinal surgery where they're putting in metal rods, but you cannot fix hips like you can fix a spine. Otherwise, you would not be able to sit or not be able to straighten your legs. We do not have that choice of fixation in hips, knees, and feet as we do in spines. Botox will produce an initial result, but like in every situation, Botox will only last 3 months. It is not going to help in the long term. And ultimately, you are weakening already weak muscles. This is not helpful over long periods of time. So we know that tight hips will prevent standing, but we cannot just think that hips are something on their own, because hips connect to the pelvis at one end, which then connects to the spine, which then affects sitting, which then affects head posture, and at the other end, the hips attach to the knees and the legs and the feet. The hips and the pelvis are a very, very important part of our function and our movement. If we are asymmetrical, if we are sitting more on one side, if we are much tighter on one side, if we have one hip dislocated, it will lead to problems at both ends. But as I say, we have no current idea of when is the best time to treat these hips, how we treat these hips, and what particularly are the long-term outcomes of treating them. If we were to treat a child at 2, would they need surgery again by the age of 7 or again by the age of 10? We do not know. These are new children to us. And these are the sorts of problems we're seeing with the hips. These are normal hip x-rays for children. And this is the sort of thing we are seeing in type 1. And notice particularly, this is the femur, the thigh bone. Look how thin these bones are. This is a child with SMA. You can see how the head of the femur is not making this angle with the leg. It is straight down. It is very hard to weight bear unless your legs come out to the side of your pelvis. They do not come straight down from your pelvis. And this angle does not form when you do not stand. And this is what happens in infants, that this posture changes to this. And the weight then forms a hip joint, which is not happening nicely here. So eventually this will just slide up and dislocate. But particularly you can see how thin the bones are. But type 3 children can have hip problems too. And these are children where there is some problem on both sides where the hip joints have not formed and the angle here at the femur is not coming out and the bones are still thin, and this is in an ambulant child. So it can happen in type 3 as well. And then we get little surprises that we have a type 3 who has problems of the hips, but also then has spina bifida occulta, something that is an extra is related to that child, and that is when the bones of the spine at the bottom have not formed properly. And it may never affect them. But if it's a girl, it can affect pregnancy because as the pelvis expands, it can cause problems. And although it's an incidental finding, we wouldn't have known if we hadn't wanted a hip x-ray. It is an important finding for that person. This is a child who was walking, who should have had good hips. But this is the problem. Again, thin bones. and very, very poor hip joints, a very oval pelvis instead of a wide pelvis. So there are many, many problems we are seeing with the hips in SMA that we need to start managing. But then we need to know that the children are suitable for surgery, that we think about what that child will need afterwards, and that we put in, and parents are prepared to help, to put in a lot of physiotherapy after surgery. So as a physiotherapist, for me, is there a difference between children on treatments and not on treatments? In a global sense, yes, but on an individual level, no, because I am still treating the child in front of me at that time. So whether they are on treatments or not on treatments, child or adult, baby or teenager, what I am seeing with that infant, person, adult, is what I am treating, what I am using my brain for, what I am using my experience for, to tell me what to do with that person, treatment or no treatment. So we need to know what we need to teach the families. We need parents and carers to accept their role as therapists, and many do not like this. I understand that. Their view is, I am the parent, you are the therapist. If you truly want to make a difference, you do have to accept the role of therapist. And you will only be confident with this as a parent if you are shown well what to do, but more importantly, that you understand why you are doing it. And that is true not only of the family, the partner, the parent, the carer, but of the child themselves. Many of our children, and this is important, are taught why we are doing what we are doing. They need to understand why we are doing active stretches. They need to understand why they should stand. They need to understand why a spinal jacket is important to wear. And if the parent is not committed to the child wearing it, you cannot expect the child to be committed. But if the jacket is uncomfortable or does not fit properly, again, you have to be able to understand where it is wrong, why it is wrong, and where you can get it changed. And to make this feel as acceptable as possible to parents, carers, partners, physiotherapy should not be a burden. It should not weigh you down. You should never, ever feel guilty you did not do it. But you must understand the consequences of not doing it, if shown by an experienced therapist. There are many physiotherapists who do not have experience of SMA who will teach you techniques like Voiter or other treatments that are relevant to cerebral palsy that are not relevant to SMA. So you need good advice from someone who understands SMA, and you need to take on board that if it fits into your daily routine, it will be easier. And the children and adults with SMA must learn to accept and actively engage in their treatment. The motivation can be limited when physiotherapy is boring, when there are no results, or when it is too easy or hard, or when the expectations are too great. And disappointment is hope over reality. So we need to be realistic about what we can do. Programs must be goal-orientated. Exercise should be fun in the form of play, sport, and activity. And it is so important to understand that no progress is 1,000 times better than no deterioration. So what is a must in physiotherapy? For the physiotherapist, they must understand SMA. They must understand the different types. They must know about active stretches, exercise, sport, play, the role of seating, standing, and how to adapt to individual needs. For the patient and family, we want to reduce the burden of care. We must ensure programs do not cause pain, fatigue, or increase joint tightness, and that physiotherapy should be done in a safe way, in a useful way, and with understanding of the family needs. Important notes for parents: scoliosis happens, but you can slow the rate of progress with good management. But you cannot prevent scoliosis in all but the strongest walkers. And the other important note is that contractures do not get better by themselves. Very few children and adults do not get contractures. Some of them are hypermobile. But that does not mean that they are necessarily stronger than children or adults who have contractures. Just because you have no contractures does not mean you are strong. And in fact, the strongest children or the strongest muscles will often have the worst contractures. Some of the very weakest children have the least contractures. So we talked about assessment, and we can assess as we watch the child. I can assess from minute to minute. If I try putting them in a position, I am assessing how that position works. Do they sit better? Do they sit more to one side? Is their head good or bad in this position? We are constantly assessing with every time we move the child. But a formal assessment is to establish a baseline. When we first meet a child, we want to know what they can do. When we first meet an adult, we need to know what they can do, what they want to do, and what is limiting what they do. We need to monitor change, progress, or deterioration, to identify problems, management programs, and this will direct the interventions that we want. This is what we assess in our unit in London. Not everybody will do this. Not even in England do they do all this. This is what we do. We still measure power in many of our children. We measure joint range, and in some it's a set number of joints, and in some it's almost every joint in the body. We need to measure their function, their arms, their legs, their mobility. We need to look at timed tests for those who can do them, because sometimes, and particularly in adults, it may be one of the few ways we can see change, and this is true in the walkers. We need to assess the spine and the neck movement, how they walk, or if they don't walk, how they get around, because there is nothing more difficult than having a 5 or 6-year-old who has to wait to be pushed around. We need to assess what splints and orthotics they need, and we need to be aware of their pain, where it is, what makes it better, what makes it worse. We assess power. We assess power because it believes it gives us the answer why. Many therapists can tell you what is going wrong, but they cannot always tell you why. So we continue to assess power. We assess joint range. Hips are the most important thing to get right and are very often measured badly. We need to look at the knees. And when we talk about valgus, it's the way the knees tend to come into that knee together position. We need to look at their hamstrings, not because we are worried by tight hamstrings. We actually prefer tight hamstrings, but with all these joint ranges, we are not just measuring size, we are looking for asymmetry. And this is very important. And it is normal to look at the ankles, that is just the foot up and down, and the heel of the foot, how it turns in and out, because many of our SMA children will have a problem in the way their heel turns. We need to look at elbows and forearms, hands, and the way the hand tends to twist to the side of the little finger. But some of our children can be hypermobile, they can bend too much, and this can be a problem as much as contractures, particularly in the fingers and hands. And for some of the more able children, particularly the strong type 2s, having very mobile hip joints can actually be a problem and reduce stability around the pelvis. There are a lot of functional scales that we use. I'm not going to go into all the functional scales, that's a whole day of talking. We know that there is a lot of crazy equipment associated with these scales. I absolutely hate this. You can go and find pictures of what they look like inside. They are a horrible toy to me. This is not very stimulating when a child would prefer one of these. And although people will use this, you cannot do that now with COVID if you are wearing a mask. It's very hard to blow bubbles. We have some timed tests. It will depend on whether they are ambulant or not. We do 6-minute walk test with all our type 3s who can walk, but other centres use what we call timed up and go, which is rising from a seat, walking a short distance and sitting again. And then there are upper limb time tests as well. We need to assess spinal posture. Scoliosis is not the only problem. Kyphosis is when the thoracic spine sticks out. Lordosis is when the lumbar spine sticks in, usually because of hip tightness. We need to look at the pelvis and is it level here? We need to look at, is the spine mobile or rigid? If it's rigid, it is much harder to correct. A child who is hypermobile in the spine, who moves too much in the spine, is actually easier to treat than one who has bad rotation and a very stiff spine. And we need to know if the shoulders are level at this to see whether one is up and whether the neck is straight as well. So we know about the problems of spines, but we have to look at the spine, particularly in a standing child, even if they're standing in orthoses or a standing adult. Is the pelvis level? Does standing create a curve? Because it can. Are the shoulders level, which then has an effect, as you can see, on the position of the neck and where the feet are in relation to the pelvis. So this is really important that we assess from the top of the head to the bottom of the feet. We need to look at neck range, and the neck moves side to side, turns, and backwards and forwards. And actually there are quadrants as well, where you're looking down to one side and up to the side. So there are many movements that are important. But what we see a lot in SMA is the shoulders coming right up towards the ears. And this is a problem of pain, of tension, of stiffness, and it shows neck weakness and instability. This is our 6-minute walk test. This was built for us by the hospital. And as you can see from the 2 graphs below, it shows us how much the children can do. And this young lady could only manage 4 laps, just over 100 meters, whereas this young man got so much more. But actually, he also lost the ability to walk at the age of 13, even though at 11 he could walk 330 meters because he grew very tall. Mobility is not just about walking. Mobility is also about being able to get from A to B independently. And you may be a walker who uses a wheelchair at times. You may be a wheelchair user who stands and walks in orthotics at times, a full-time wheelchair user, or have no independent mobility. And obviously the aim would be to get as many children and adults mobile as possible. And there are different forms of mobility. This particularly is no independent mobility. Wheelchairs that are made electric with these electric motors, e-motion wheels. We like these for situations where an electric wheelchair is too big, there is no vehicle for it, or that it's too expensive. Manual wheelchairs should be lightweight but supportive, and sports style wheels, if the child is going to push, these angled wheels are better. And if the child is going to stand, then they may as well stand in a standing frame that moves. Excuse me. So these dynamic standers for children who've got the arm power are the preference. We need the correct splints, collars, foot splints, jackets, full orthoses. This is how we make our jackets. Gaiters we use a lot. We need to assess pain and what causes pain. Muscle pain is rare in SMA unless the muscle has been overstretched or damaged through bruising or falls. Joint stiffness and joint deformity causes pain. Back pain is more common among parents and carers. Pressure sores are rare but usually come from equipment, from orthotics, from the position in the wheelchair, from the position on the headrest. Pressure sores that we see in older or weaker people do not usually happen. But we do see a lot of fractures, and there are micro fractures when the bone is very poor quality, and micro fractures are particularly seen around the knees when the bone is thin, and you have to be aware that pain around the knees may be micro fractures, and this can be treated. We need to be aware that age and assessment are not exclusive. We can assess babies, but we do know that babies and children can fatigue, and so we need to be aware of that. There are many assessments that do not fit the child, and the child appears to have a bad score, but it is more a problem of the assessment than the child, because every child is individual and every assessment is not. Then you must accept that if your child seems to be quite low scoring on the scale, perhaps it is a problem of the scale and not your child. And a physiotherapy assessment, whether it is in clinic or research, should not be scary, should not be tiring, and not be too hard, because there is nothing worse for a child than being made to fail. And when we have a child who can walk, we will ask them, can you get up from the floor before we put them on the floor and make it difficult because they cannot get up. So we give the child the choice. Do you want to try getting up from the floor? And if they say no, that is fine. You would not put an adult on the floor if they didn't want to go. So why would we put a child on the floor if they don't want to try getting up by themselves? We need to look at the home, school, college, the therapy, what activity they're getting up to. And the assessment is only part of what we do because it's the results of the assessment. We know, we have said, weakness causes respiratory problems, contractures, scoliosis, decreased function and mobility and fatigue. And I can say that all day because this is what we have to treat, which leads to the problems that we've already talked about. That is the end of the first part. Olga, I don't know if we're going to take questions at this point or we're going to go on. We could take some questions at this point. Okay, so I will stop this screen and I will look for my little globe and put English.
Yes, да, Мерион. Спасибо большое. Мы сейчас, наверное, какие-то вопросы зададим. И есть вопрос, который звучит следующий. Как вы относитесь к терапии детей с астмой на виброплатформе Мерион?
Okay, I've heard a lot of questions about vibrating platforms. To ask, can you put an SMA child on a vibrating platform? The answer, of course, is yes. You can put anybody on a vibrating platform. The question is, will it do any good? What are we expecting vibrating platforms to achieve apart from shaking you so much that you feel very strange? The first important thing about vibrating platforms is they are supposed to help bone health. But if you are very contracted and you cannot stand, where are you putting this vibrating platform? Are you sitting on it? Are you trying to stand on it? Are you putting it under your feet? And if you are very contracted, yes, it will vibrate all the way up to your head, but is it going to change your bone health by itself? So bone health is one aspect of vibration, and in standing frames, some standing frames are now including vibrating plates to try and help with bone health. Because standing by itself, static standing, is not necessarily seen as the best way to improve bone health. And that movement, the actual hitting of the foot on the floor, the vibration that causes through the whole body up the spine is the thing that improves bone health. We don't know then what the effect on arms is of putting our arms on vibrating plates. Do we want our arm health and our arm bones to be stronger? Because I don't think anybody has looked at the effect of hands on vibrating plates as to whether it improves power around the shoulders and arms. The other use of vibrating plates is for exercise. Now, to be able to exercise on a vibrating plate, for those people who have tried, this is not an easy thing to do. And in some cases, it's actually not very pleasant to have this vibration at a level that challenges the muscles. So that if you have a level of vibration that will challenge you, it can feel a little strange. But for it to challenge you from a muscle point of view, it needs to be placed in the right position. And like with all exercise, you need to be exercising the correct muscles. if you are exercising the muscles that bend the hips, bend the knees, point the feet, you are not going to gain from it. So that you need to know which muscles you're exercising to challenge on the vibrating plates. So using a vibrating plate to sit on, to stand on, to put your feet on, needs to be done with some thought about what you want to achieve and how you are going to achieve it.
Спасибо. Вот здесь в продолжение этой дискуссии виброплатформа стимулирует и укрепляет мышцы, говорят специалисты, которые их рекомендуют. Вот так ли это?
Sorry, can you repeat that question?
Виброплатформа стимулирует и укрепляет мышцы, так ли это?
This is what I've already said. To strengthen the muscle, you have to make sure it is the correct muscle. It will not strengthen muscle if the muscle is not doing any work. Just vibrating a muscle will not make it stronger. Muscle has to work to make it stronger. The only way you can add an external stimulus that will make the muscle even the smallest bit stronger is with electrical stimulation. But it still needs active work by the muscle with the electrical stimulation to make improvement. Muscle is not a passive creature. Muscle needs activity to make power. So vibrating it may feel very nice, but you have to work the muscle. You cannot just put vibration in it and think it will get stronger.
Спасибо. А как вы относитесь к миофасциальному релизу при СМА? Myofascial release. Myofascial release.
Myofascial release.
Yes.
It's a very interesting term. It's more related to contractures, but it's not something I have an awful lot of experience of, and I couldn't honestly say that I would know the benefits of myofascial release. We talk about myofascial problems in terms of muscle length, but muscle length by itself in the normal situation is different from a contracted muscle that may be fibrosed or has other structures that are also tight. So my honest feeling is I do not know enough about myofascial release to know if it is useful in SMA. Something for me to actually look up.
Можно задавать следующий вопрос, или вы пока смотрите?
No, I'm not looking it up now. It's going to be a big job.
Okay. 4 года ребенку, сам стоит, не ходит, может только пару шагов пройти за руки. У ребенка двусторонний подвывих по Реймерсу 31 градус с двух сторон. Нужен ли СВОШ? Мы не слышим переводчика. Так, мы не слышим перевода. We can't hear the translation. I will translate you then. The kid with SMA, 4 years old, could stand but cannot walk. Could walk only with the support 2 steps. The child have 31 degree on Reimers. Двусторонний подвывих. I will check how to translate that. Yes, thank you. From 2 sides, and do we need to use SWOSH?
SWOSH braces for cerebral palsy.
Yes.
It is for spasticity. It is to stop the child adducting, bringing their hips together within cerebral palsy. So a swash brace would probably not make a big difference in a situation where the muscles around the hips are weak and the hip joint is not.
Можете мне тогда английский звук сюда вывести?
Because in a bilateral dislocation or subluxation, you must understand that the joint is not formed properly, and in a 4-year-old, there will already be X-ray changes that show that the hip is not a normal shape. So brace may give stability to the hip and allow the child to walk, but it will not change the hip dislocation or actually change how well the child is walking. The hips are not the only problem in a child who can only take 2 steps. And we can walk with dislocated hips. If they are not painful and they are not contracted, then you can walk with dislocated hips.
Спасибо. И у нас очень большой вопрос, я его уже отправила переводчикам. Добрый день, у меня СМА 2-3 тип, 55 лет, мучаюсь импульсной болью с 2006 года. Она просто прибивает меня все от грудного отдела до сплетения затылочных нервов в голове, и с каждым годом все сильнее. Операция по выравниванию сколиоза с укреплением титановой конструкции была в 2011 году и помогла унять эту боль почти на 2 года, но боль вернулась. Пробовала очень много обезболивающих, но они не сильно помогают. Принимаю сейчас блокатор боли, но плохо помогает. Что можно сделать? Что можно медикаментозно, может быть, применять? Или, может быть, можно применять что-то еще?
It sounds like you are already taking a lot of medication. We are seeing a lot of hip pain and a lot of hip problems. The question would be, you say you are SMA1. The question would be whether surgery could, better surgery, even reconstruction, not of the hip joint, but possibly around the hip to try and relieve the pain. The question has to be, what in the joint is causing the pain? Is it the position? Is it the shape? Is it the problem with the way the head of the femur, the thigh bone, is sitting? And it may be that painkillers are the only answer. And many people are taking a lot of painkillers for hip pain, but we need to look at the doctors and ask what surgery may be helpful. If the hips are very contracted, would releasing the muscles help with the pain to allow the mobility of the hip to improve? There are many questions we do not understand about the hip pain and the benefits of surgery. But ultimately, you can keep taking painkillers. But again, the problem of painkillers is it kills the pain for a short time, but it doesn't correct the cause of the pain. What we need to try and establish is the cause of the pain and take away the cause. And that may only be possible through surgery.
Нужно ли ребенку, который начал получать лечение спинразой, делать лечебную физкультуру больше и чаще, чем до лечения, чтобы эффект от лечения был лучше, или достаточно той нагрузки, которая была до лечения? Marion, you can't hear the translator now. Okay. No. So the question is, do the child which start to using Spinraza, there is a need to do physical therapy more and more often than before the treatment, in order to make the effect from treatment better, or there is enough the same activity as it was before the treatment?
It's important to understand that Spinraza has some negative effects as well as positive. What we are finding in many of the children on Spinraza is that while they are stronger, sometimes they are making more contractures. So that sometimes the strongest groups are getting stronger and making the hips, the knees, and the feet tighter. And therefore, physiotherapy may need to be more regular, not necessarily more intensive, but more regular to work the opposite muscle groups, the muscles that straighten the hips, the muscles that straighten the knees, the muscles that pull the foot up. The stretching must be active. We will talk about this in part 2. But actually, a lot of doctors will tell you, a lot of neuromuscular doctors will say that the benefits of all these therapies are improved with more exercise, more activity, more sport. But that does not necessarily mean more physiotherapy. The physiotherapy should be directed very much at maintaining posture, spine, joint range, and the family and the child or the adult should direct their attention at increasing their activity. That is what is important. The role of the physiotherapist has not changed. The emphasis has changed. It must be more joint and posture management, and the family, the child, the adult, the baby, whoever must do more activity. Build activity into every day, but we will talk about exercise and joint range in part 2.
И насколько интенсивной в идеале должна быть физиотерапия для маленького ребенка с астма? Тип 2, который еще не способен до конца оценить ее пользу для себя, нужно ли следить за тем, чтобы ребенок не переутомлялся, или нужно каждый раз давать ему челлендж, чтобы он напрягался и немного уставал?
Firstly, do not tire the children. Fatigue is real in SMA. Fatigue is not just about the muscle, but about the amount of nerve impulse that is getting to the muscle. So this is not just about tired muscles. This is actually about inability of the muscle to work anymore. And if you fatigue it too much, the effect can last for up to 2 days, where the muscle cannot function properly until it has well rested. So we do not push the children to fatigue. We push the children in short amounts. We push them in the correct way. We encourage swimming. We encourage certain activities. But fatigue in adults, children, and particularly in babies, you must appreciate that babies with type 1 or weaker type 2 also fatigue. You cannot keep pushing and pushing. Their movements are slow, they are difficult, and they are tiring. And these babies need careful handling, careful assessment, and directed therapy so that you are getting the most out of them in the shortest possible time. Better for the most fatiguing patients to do a small amount several times than one big exercise or 2 big exercise sessions. Much better small amounts throughout the day.
Спасибо. И еще 2 вопроса я задам, прежде чем мы дальше пойдем по второй части доклада Мейна мы продолжим дискуссию. Я вижу, что остались еще не заданные вопросы. Один из вопросов, он в продолжение того, который только что был задан, и про взрослых. Как переутомление и перетренировка могут влиять на течение СМА? Может ли это спровоцировать ухудшение у больного СМА как у ребенка, так и у взрослого пациента?
If you fatigue a child or an adult too much, then their muscle can stop working. This is physiological fatigue. The nerve impulse is not getting to the muscle, and so the muscle cannot work anymore. So it is better when you see a child fatiguing. We have seen type 3 children who over the course of an assessment are getting more and more tired. If you see the child getting tired, if you have a type 3 who is getting tired, which then leads to falling, then you are going to have sprains and fractures. We know that the children fall more when they are tired, that the children with type 3 will walk on their toes more when they are tired. This is because their muscles are tiring and need extra help from different muscle groups. We do not want to get to that point. We don't want the children falling. We don't want them walking on their toes. Now you can see this easily in type 3. It is not so easy to see it in type 2 and type 1. But if the child's head starts falling, if they are doing this to keep the head up, if they're their posture is changing and getting worse, you know the child is fatiguing. And then you must stop or reduce the exercise and start after a rest.
И последний вопрос, спасибо. Кроме активных техник физической терапии, используете ли вы массаж, аппаратную физиотерапию, магнита, лазера и так далее, механизированные, роботизированные приспособления?
Massage, no, basically. Massage is one of those lovely things we all need. If I were going to give massage to anybody, it would be to the parents. They are the ones that deserve a massage. Massage can warm a muscle before exercise, but it is not an effective treatment to build power. It feels nice. Every mummy deserves a massage at some point. And we should have them free on the health service. We do not use a lot of robotics, but there are machines that you can stand in. There is one called the Inner Walk that is like a standing bicycle. And this is fine if the child or adult is doing the work. What I do not accept is when the machine is doing the work. So if the machine is doing the work, it is passive and it is doing nothing. If somebody were to come and move my arm for me all day, it would make no difference to me. They would fatigue, but it would not change my arm. Passive does not work. We will talk about this. If any of these robotic systems or exercise machines are active, they will work. But obviously, the more the child is working, the more we have to think about the level of fatigue. The same for adults. Adults with SMA also fatigue quicker than in the normal situation. Being an adult does not stop the fatigue.
Спасибо большое. Я думаю, что мы перейдем ко второй части доклада. Мерин, нам нужно взять минуту перерыва на переключение презентации.
We had trouble finding part 1, now I have to find part 2.
Мы сейчас буквально на 1 минуту прервемся для того, чтобы запустить следующую презентацию. Мы продолжим разговаривать с Мерион.
Okay, now I have opened the second presentation.
И мы продолжаем.
Talk about encouraging activity. Oh, can I just ask the interpreter, am I speaking slowly enough?
Уважаемый переводчик, достаточно ли медленно, Мерион говорит медленно, чтобы вы успевали переводить?
Okay.
Да, отлично, мы продолжаем.
So the second part of the talk, I was asked to talk about encouraging activity in adults and children to improve range of motion and physical activity. Encouraging some adults is impossible. We know this. Encouraging children will depend on how much the parent is prepared to do battle. So we need to look at making patients more active. Passive and active approaches to SMA rehabilitation and physiotherapy and exercise. We are going to talk about what should the patient be doing himself and with the family. We will be looking at how to encourage activity, examples of exercise and practical tools, and what an ambulant patient can do for themselves. And in my talk in part 2, I have particularly tried to look at both adults and children. At some points, we will have to talk about from the very weakest to the very strongest, but we need to think about modifying everything to suit the individual. This is again about each person being different. So passive and active approaches. I do not believe in the passive approach to physiotherapy. Passive movement does not educate muscle or improve power. It is as simple as that. Passive movement can help to mobilize joints, but once you have mobilized it, there is no power to keep the range. So if you do it passively, it will stay the same or possibly get worse. Standing is passive. It is static. Standing in standing frames has its place for those who are able. Standing outside of a standing frame on their own or in orthoses is more effective. And if the child can stand, if the adult can stand outside of a standing frame, they should spend periods in the standing frame and equal periods outside it. And again, with passive stretching does not maintain range. It is passive. Stretches and exercise where possible should be active. If I only make you understand one thing, it is that. Active stretches are stretches where the person having the stretch, the infant, the child, the teenager, particularly the adult, is actively taking part in the stretch. The muscles are working to help produce movement. Even the weakest muscle you can try and contract, even if it does not move. The effort of trying to contract the muscle is enough. But to do that, they must be actively working with you. So if we were talking about the Achilles tendon stretch, When you are doing stretches for the foot, as in the picture, the child should be working. It is not enough for a parent, a therapist, a carer, or a partner to be doing all the work, because the only effect will be in their biceps muscle. So they must be pulling up the foot, because for a start, this prevents pain and injury. If the child is working and not fighting by pushing in the opposite direction, it will reduce injuries. It will increase the range through relaxation of the muscle being stretched. If the child is pulling their foot up, the muscles of the calf will relax. The brain knows you cannot be doing opposing movements at the same time. You can have what is known as co-contraction, opposing muscles working together, but that is static for co-contraction. In the movement situation, you cannot have opposing muscles, a muscle that pulls and a muscle that pushes working at the same time. It is not possible. The brain knows that better than most physiotherapists. So if the child is pulling their foot up, the muscles of the calf relax, and so you will get a better stretch. And if the child is pulling their foot and the movement increases, then pulling their foot will help to keep that new extra range from being lost the second you let go of the foot. And that is what is so important in active stretching. What causes contractures? Basically, weakness. Otherwise, we would all have contractures. It is the inability to move the joints. It is caused by asymmetrical muscle pull and asymmetrical power. One muscle pulling in one direction and the opposite muscle not being strong enough to stop it. That is one of the biggest causes of contractures. But we have persistent posturing, being in the same position all the time, as in the lower picture. The child who is constantly in frog leg position is going to get tightness of the hips, the knees, and rolling in of the feet. Contractures are caused by growth. The bones grow first and the muscles must stretch to fit with the longer bones. So if the bone has got longer by growing, then the muscle must get longer too. Otherwise, all that will happen is the joints will bend to allow the muscle to stay the same length. This is the problem of growth and rapid growth in children that does not happen in adults. And exercising the wrong muscle, as we so often see in cerebral palsy treatments, in some of the mechanical treatments, the spider cages, the webs, the different things, even Voiter exercises the wrong muscles, it exercises the strong muscles. So if you exercise the strong muscles, you will get contractures. Where do contractures happen? They happen everywhere there is a joint, which includes the jaw, it includes the neck, and it includes the spine, because scoliosis is a contracture and can be stretched and should be stretched. It won't cure it, but it will help the spine getting stiff. We know contractures can appear from very, very young. I have 6-month-old babies with hip tightness, and inability to turn the hand fully into the palm up position. They can occur, as I said, in any joint. They can appear on one side or both, and they can progress rapidly, as in growth, or very slowly, as in adults. Contractures do not get better by themselves. They need daily care. To prevent stretches and joint range treatment being boring, it should be done as a routine. So you can stretch hips with nappy change in babies. You can stretch hips in the morning and the evening when the child is still on the bed during the day. Every day. We do not have weekends off for contractures. Contractures do not take holidays. They do not go away when you do. Contractures need daily care. They can be made into games for children and should be made into games to stop them from getting boring, both for the child and the adult. And for adults, if you want your contractures to improve or not to deteriorate, then you must do them with some commitment, not once a week, not half-heartedly, not without any enthusiasm or positive reinforcement and intervention. So we will maintain joint range through active assisted stretches. For some children, through self-stretches. Passive stretches is only for babies, but we would still talk about pull, push, do this, pull your toes up. Even the tiniest baby, we will say, pull your toes up while we are doing it. You can maintain joint range through exercise, such as yoga or Pilates. You can do it through splinting, and this is really important. Through positioning, through standing, through good sitting, through good lying. You can do it through serial casting, and you can do it through surgery, but none of them will stop contractures from forming. They will help. This is the position for the hip stretch. We do not turn babies, children or adults into face down prone lying. We stretch the hip in this position. We can ask the child to hold this leg while they are pushing this leg down, not the foot pointing down. The whole leg must be pushing to stretch this hip. So this hip comes up to flatten the arch in the spine and flatten the pelvis. And it is in this position when you see how tight the hip is. You cannot measure the hip in any other position. And this will show you where the tightness is, as I showed you in the picture from the last section of the child over the edge of the bed. That is the place you need to look over the edge to see hip contractures. So with nappy changes, if you have a changing table, it's over the edge. If there is a problem with doing this on the bed, you can do it on a settee. But this is the best possible position for stretching hips. For feet, you can do this with them. You can do self stretches. You can do towel stretch. You can either do a straight stretch or you can do an active stretch. And this is passive, this is active, where you are pushing the knees straight and pulling the foot up. And this is the same but better. And this is actually the elastic band, so that you are working against the resistance of the band, but a towel or a scarf is fine. And this is how we like the children to stand to stretch here. and we ask them to put the heels on the floor and the feet up, not on a step with the heels hanging down, because this can overstretch the bottom of the feet. And we say that this is the best treatment. This is Harry Potter, and you will notice this is the first book, this is the last book, and each one gets bigger. And so the bigger your feet, the higher you will go up the books. We can also use them for step standing, which we will talk about in exercise. So you don't have to read them, but it would be useful to have a set to do your exercises. Elbows and hands, a good way of stretching arms is to weight bear on the hands. But if this is not possible, to do it on feet and hands, do it on knees and hands for the children who can crawl. Help them if they need it. You can do Play-Doh, hand pictures. You can do the same self-stretch you are doing for the ankle to stretch the fingers. You can pretend you are pushing a broken down bus, and elbow stretches are important. So how much force? In effect, if the adult is pulling, you shouldn't need to use much force at all. But you must feel the muscle. It's about thinking, can this muscle stretch anymore, or does it feel so tight I have come to the end? You must, when you are doing stretches, do it in the line of the muscle action. Very often, children and teenagers, when they pull their foot up, they will pull from either the big toe twisting in or the little toe twisting out. They must learn to pull the foot up straight. So if they pull from the big toe and twist in, you must say pull from the little toe. And if they pull from the little toe naturally and turn out, then you must say pull up from the big toe. It's really important. If you want a good stretch for the ankle, then the foot must come up straight, not twisted, because if the heel is twisting, then the Achilles tendon is not stretching. You must always stretch slowly. They should never be done fast. We know the muscle reacts badly to fast stretch. When you are having your reflexes tested, this is fast stretch of the tendon. When they hit your knee with a hammer, it is testing the stretch reflex. If you test fast, you will incur the stretch reflex and get the opposite reaction to the one you want. They must be stretched slowly to stop reflexes getting in the way. You must think about normal range and not trying to get more than normal. And stretches should never cause pain. There is no issue that pain is ever right. It is wrong. It is damage. It makes you reluctant to have the treatment again. We can use splints to maintain range. We make, in clinic, these soft cast splints. It takes us 20 minutes to make a pair while the child is there to wear in bed at night. They are very soft and comfortable, but prevent the knee from bending. If the knee is already bent, then they can be made in that position. They can be made for elbows too. We wear night splints for the children whose feet hang down. If they cannot tolerate them at night, they can wear them during the day. But this is to maintain, it is not to stretch. It is to maintain this good standing weight-bearing position, and gaiters, which we use frequently in all our children to keep the knees straight, to encourage weight-bearing. But they cannot be used with a bent knee. These are only for straight knees of a contracture up to around maximum 25 degrees at the knees. And we can use these gaiters for stability. This is a young man who had instability around the hips on one side, who could not stand fully weight-bearing on that leg, that made him look very asymmetrical with a curve in his spine. And this was what happened when we put on one gaiter. It gave him stability at the hip and brought that foot down. So if we had left him, he would have had curvature of the spine, he would have had tightness of the ankle, and he would have had a problem with his hips. And that was a young man with SMA 3. We go for position, we go for standing. You're standing in a standing frame, stand in one of these. This young man is type 1 SMA. He is on treatment. His mummy is very proud of his achievements, which is why his photo is there. And he pushes this around at home. As it happens, he was in the hospital, so he showed us his pushing in the hospital. This is one type of dynamic stander. This is CAFOs. This is freestanding in CAFOs, and we do a lot of it. Even if the children cannot walk, we put most, if not all, of our type 2 children, and now many of our stronger type 1s, into CAFOs. We need good seating for good posture. We have this sort of seat, but this is not necessary in SMA. It is pushing the legs outwards and actually making the posture worse, and the feet are pointing down. We do not like this wedge in the middle. If a wedge has to be anywhere in SMA, it must be on the outside, not the inside. We have this is the same as these pieces here, and this was a young man with type 1, and we just took the pieces from this and built them so that he could sit. It had never been possible to sit this young man. Everybody said he would never sit, and he sat beautifully in this position. We want the children sitting. We do not want them spending their lives lying down. It is very hard when your only view is of the ceiling. And we can have these beautiful built-up chairs that can be on wheeled bases, that can be comfortable as well as functional. This is one of our UK electric wheelchairs. This is the same young man as this when he was younger. This was when he first learned to drive it. He drives it beautifully everywhere. It is his life. And we try and get every child who has reasonable head control into this sort of wheelchair by the age of 2. Good posture is important in sitting, in standing, and in lying, but we do not use spinal jackets when the children are in bed at night, because we do not believe scoliosis is a problem of lying. We believe it is a problem of keeping the trunk and the head up against gravity. But we need good posture. Even though we will get scoliosis, we want the spine as straight and mobile as possible. Can physiotherapy help posture? We can do activities for teenagers and adults such as Pilates. It is difficult, but there are modifications. We can do it through exercise, and we use the bands to help us exercise, the elastic bands we use to help us exercise for our posture. Whether we can use yoga is quite difficult, but no different from Pilates. We need the children sitting properly at school and adults sitting properly in the workplace. So we need to do a lot on seating and positioning, mostly during the day. We don't use a lot of positioning at night. Many countries, you will have the children in special sleeping systems at night in bed. We do not use them, and the reason we do not use them is if a child needs turning at night, it makes it much harder for the parents to then change these sleeping systems as the children change. If we want them to wear night splints and they are already wearing BiPAP or other respiratory adjuncts like a vest, it would be impossible to have a sleep system as well. So we do not tend to use sleep systems, but we can use modified pillows and cushioning, and we have special roll systems that will stop the legs from rolling out that are much easier to use than a whole sleep system. We do a lot of serial casting. We like to make the casting fun, but on the very smallest children, they don't need the coloured plaster. This is really only for weight bearing or for the children who are going to be bashing their legs around in a wheelchair. So this is plaster of Paris. This one actually was covered in fiberglass, but a softer fiberglass. And in fact, these are fiberglass splints, as I showed you before the soft cast, because it was felt that plaster would be too heavy for this child. And we got quite a nice improvement at the knees. Any ambulant child needs to walk in the casts, and we will talk about that. Now, there is a problem with casting knees, and that is that it makes it very hard to sit with your legs stuck out. But we also have to consider getting the child to and from the hospital. And this young man was supposed to have his knees cast, but they couldn't have them cast until they got a new vehicle, because he couldn't sit in his car seat in their car because his legs would have been a problem of position. So we cast them only when they got a new vehicle. And we need to be aware when we are casting knees, if the child normally stands and stretches their hips in standing, we must add extra hip stretching when they are having their knees cast, because as you can see, when the knee is in this stuck bent position, then when sitting, the hips are also very bent. Now, this is a young man with type 3 SMA who came to us only walking on his toes. We put him in casts and he walked in the casts. All ambulant children must walk in the casts. And within 2 weeks, we had his heels down. This was 6 or 7 years ago, and he is still walking like this. That is commitment on behalf of the child and the family. Not many children would have managed to keep their feet down without a lot of work over 6 or 7 years. We may tape under the cast. If the foot is twisting in or out, we will tape the foot into a neutral position and then cast. It gives a much better result. We will also do padding. There is tape on these feet to correct the hind foot, but also padding over the front of the foot and over the toes and at the bony parts to ensure, and underneath here, as much padding as we need to make sure those casts are comfortable. Now, the most important thing is we can cast, we can do surgery, but if you are going to sit in the same position the whole time, you are going to get those contractures recurring. This young man always sat on the floor. Even at 8 years old, he sat on the floor. As soon as he came home from school, he sat on the floor. All weekend, he sat on the floor. And this was the posture. This is after foot surgery. So he had already had surgery for his feet and the contractures came back. We put him in plaster and corrected his feet and took him off the floor because we said we will not do it again if he does not take away some of the problem. He can keep his feet like this if that's what he wants. These surgery, casting, splinting are treatments. They are not cures. They don't take away the problem. You need to think, I am going to have surgery or I'm going to have casting. How do I keep that range of movement? But many of our children will need surgery for their feet. We do not do knee releases. Very, very rarely we accept the hamstrings are released because it is both painful and ineffective. And the surgery is basic. What's important for management is to get it right afterwards. Taping does not cure contractures or control or maintain range in any length of time. It can help over short periods, but again, taping has to be done with other treatments, with exercise, with splinting, but particularly with exercise. Tape by itself is not a cure. We need to manage weakness. We need, particularly with the new treatments, to make sure we are using the power gained correctly. We need to understand the importance of exercise, activity, sport, and play for every age. We want to increase stamina and power, but we do it by low weight, high repetition. We do not use big weights, not because of damage to the muscle, but because of fatigue. Exercise does not damage muscle in SMA. It can fatigue muscle. It should never cause pain, and we should never, ever be exercising the wrong groups. Good exercises are symmetrical exercises. They target the right groups. They are achievable. They are fun, and they are effective. The bad exercises are too hard or too easy. This does not improve motivation. They are boring, which is totally unacceptable. They are exercising the wrong groups, which will increase contractures. They are using excessive weights, which will cause fatigue. They are asymmetrical, so only one side gets stronger, causing more problems of asymmetry, such as curvature of the spine. Are hazardous. They are dangerous. They cause pain or injury. Many, many people suffer from disuse atrophy. Probably everybody in the world has some disuse atrophy. It is weakness caused by lack of use. There are hundreds of muscles in the body. There are some that we all will not use on a regular basis. Therefore, the muscles will shrink if they are not used. The one muscle we can probably say that most children with SMA do not get shrinkage of is the tongue muscle. It gets plenty of exercise. But there are many other muscles when you are sitting down all day that do not get work, even though they have the power to do some. I am not saying that they can do a lot, but when you are sitting on your butt all day, and this includes everybody who sits all day at a computer, there are muscles that are not working, and over time they will get weaker. So disuse atrophy in SMA adds to the underlying weakness and can cause extra problems. And without treatments, most of strengthening that we do is working on disuse atrophy. It cannot be strengthening the weak muscle. in children and adults not on treatments. So on treatments where there is the potential for the muscle to improve, this is why we need to exercise. This is not disuse atrophy. This is weak muscle and needs building up, but needs building up correctly to stop contractures and problems. Play is exercise. This is the way children learn movement. Play is the work of childhood, and children should be encouraged to play to build up their power. That is what children normally do, and we should be encouraging it in SMA children too. There are exercise videos on YouTube directed at SMA. You can go on, some of them are better than others. Some of them are longer than others. So there are things on YouTube that are available for people with SMA if you do not have a physiotherapist who can help you. But physiotherapy that is family friendly will be more effective. So if everyone can play, if everyone can swim, if brothers and sisters can do activity together, then it is more likely to get done and more likely to be effective. How much and how often? You should be doing, and that includes parents, carers, and everybody listening to this, should be doing daily aerobic exercise or activity for a minimum of 30 minutes every day. Aerobic exercise is the exercise that makes you a little bit warmer, your heart rate a little bit faster, and your breathing a bit faster too. We are not talking about exhaustion. We are talking a little bit warmer, a little bit faster heart rate, and a little bit faster breathing rate. Adults, motivation and commitment. Many adults will not be interested in exercising. It has never been effective. It has never been fun. It has never been something they do. Families where your parents, where your siblings exercise, the child or the teenager is more likely. But if you come from a family whose whole activity revolves around picking up the remote control for the television or putting your Xbox on your knee, you are not going to find a very motivated person to do exercise. You have to understand, not only does exercise help your SMA, but actually exercise has a very natural pain relieving effect, and there is a natural high you get from exercise because you release hormones called endorphins, which make you feel better. So exercise can not only make you functionally better, but it can make you feel better too. But exercise must be regular to be effective. If you do a program for 6 weeks and improve your power and then stop, all the effect of that program will be gone in another 6 weeks or less. But you must set realistic goals. You must make it part of your daily routine to be done. And if you can do it with a family or with friends as a Zoom group or at an accessible gym, you are more likely to be motivated. You may be able to find an instructor who understands or can learn to understand SMA to help you. For children and motivation, it must be fun. It must be regular. Children like routine. Vary the positions. Do not do them all in sitting or lying. Some can be done in standing. Some can be done in side lying. They may be done in different parts of the house, on a different seat, on a different bed. Sometimes a nice big squishy bed is a great fun place to play. Again, play is exercise. If the child is doing sport or activity, if they are horse riding and swimming, then that day they do not need to do an exercise program. They should not be doing swimming and an exercise program. That is fatiguing. If you find it fun as an adult, then usually the children will too, but that does not apply to teenagers, because if you find it fun, then teenagers will definitely think it is awful. But beware, teenage in girls starts at 9. 9-year-old girls can be equally difficult as 15-year-old boys, and any mother of a 9 to 16-year-old girl will understand that. We need to be creative with play and exercise. We need to take away the phones, the TVs, the iPads and the Xboxes without causing a revolution, a war, or a child who is so unhappy they really will not cooperate. We need to find fun and creative ways to play. We can use household tasks to exercise. We can make bread, we can bake, we can even do some housework. And we can find interesting ways of using household equipment to make play fun. Many children are equally happy with a set of pans and spoons as they are with electronic equipment if this is done with fun and regularity. We need to think about the core. It is very, very hard for people with SMA to work their abdominal muscles. It's usually only effective statically. Otherwise, you end up overusing your hip flexors. So you can use your core, but if you just end up using your hip flexors, then you will find that you get tighter joints. Now, there are Pilates videos for people with neuromuscular conditions on YouTube. They were made by some Pilates experts in the UK. They are available for everyone. They were made with neuromuscular conditions in mind, but they are not specific to SMA, and so are hard for most people apart from some of the stronger 2s and 3s. So they were made for a lot of other neuromuscular conditions as well as SMA. But be careful when you are looking for core exercises on the internet, because these are the sorts of things that you will find, and they are impossible for most people with SMA, and to be honest, impossible for most normal people too. These are the activities that we encourage for ambulant and non-ambulant children. Martial arts, some can be done from the wheelchair. I know, because a friend and I were doing martial arts workshops for children. Balls, peanuts are great places to exercise, but must be done safely with care and understanding. We use a lot of the exercise bands, particularly for shoulders and posture, but also for knees. We use cycling with adapted bicycles, horse riding we love, Pilates for the teenagers and adults when you have a good instructor, and swimming as much as possible as the best possible exercise for SMA. Don't forget hands and fingers. There are many things you can do. Great way of improving your respiratory, maybe through musical instruments. Great arm exercise to play the piano. You can be doing all sorts of things with a musical instrument. Do not forget musical instruments as a form of exercise. We can use squishy dough for fingers. We can use elastic bands, something simple that you find around the house. We need to look at shoulders. We can play games. We can use the balls. We can do wall press-ups, but you can sit and do press-ups as well. Anything that involves weight bearing, crawling, this is weight bearing. You can do this sitting in a wheelchair, wall press-ups. This is hard for the stronger children. Step standing for any ambulant person or better type 2 is a great position to improve pelvic stability. So you have one foot on a step or a correct Harry Potter. The weight is going through this leg. The pelvis is working hard. The hips are working hard. You could be doing your Xbox here. You could be watching the TV here, but don't forget to change legs. Bridging on a peanut. We love the peanut. This is a peanut. We can do bridging. We can do lots of other exercise and activity. We can do sitting, but beware, they can fall off. Make sure if anybody is doing a ball or peanut, there are no obstacles around. You can do balancing, you can do core, you can do stability, you can do shoulders on balls and on peanuts if you can get onto them. They need to be safe. With the children, we often sit in this position, but with the legs forwards. We can do arm exercises. We can do spine exercises on a ball or a peanut. Even the small babies and children can do this sort of thing. Not this, but certainly this we use a lot in the babies and children. We can do this sort of thing where you have a plate of marshmallows or sprinkles that they can get their face into. Something fun to play. We can do ball dancing. For the stronger children, their feet must be on the floor. The ball must be the right size. But we can do ball dancing. We can watch TV. We can do other things, challenging our core and our balance. We can do shoulder exercises on the ball. Finally, I want to talk about parents, because we're talking a lot about children and adults, but parents, carers, and partners, you need to look after yourselves too. We are children's physiotherapists, but we believe we need to take care of parents, and we need to make sure they do not have pain or injuries or back problems. So we need to get them to look after themselves as well. Parents, carers, partners are important. It is not good enough to say it is all about my child. It is all about my partner. We need to think of everybody's health. Partners, parents, and carers need to exercise, and we need to think about carrying children, teenagers, adults, particularly on stairs and the dangers. So the take-home messages from today: physiotherapy by itself is boring. Children are not small adults. They have different situations, different rates of progress and problems, and unlike adults, they are growing, and that causes a lot of problems. And despite any research which will tell you what you should and should not be doing, whatever your assessment says, we need to make programs and think about what we are doing with each individual child and family. When we make programs at our hospital, in our physiotherapy team, it is made for that person alone. We do not share exercise programs. Yes, we will use the same exercises for more than one child, but each program is tailored individually. What we do now is the results we get in the future. Bone health, contractures, posture. Do not wait if you are on treatment or not on treatment. If you are a baby, an infant, a child, a yucky teenager, or an adult, you can still be doing your physio if you've never done it before. We need to anticipate and prevent. We know about contractures. We know about scoliosis. We don't wait for them to happen and then complain they are there. We have treatments. They do not cure contractures or mend scoliosis. No child is lazy. Lazy is a teenage problem. There are papers written about the need of teenagers to sleep the clock round. Unfortunately, most of them do it from 3 in the morning till 3 in the afternoon. But we know that children are not lazy and they need fun and motivation to work. And most of all, I could not have any of that experience I have without the teams around me and the most amazing parents and children I have ever met teaching me everything I know. Thank you.
Спасибо, Мэри.
Questions?
Да, и у нас большое количество вопросов. Пожалуй, я начну с вопроса относительно ортопедических приспособлений. Добрый день. С какого возраста нужно использовать корсет, если симптомов искривления позвоночника нет и пока нет деформации грудной клетки? И можно ли усаживать ребенка в домашнюю активную коляску без корсета? Очень с ранним началом, с ма-1, ребенку 9 месяцев, но первые симптомы появились в первый месяц жизни.
The spinal jackets can be preventative in type 1, even without any scoliosis. So it will depend on how strong the child is. Yes, they can be sat in a wheelchair without a jacket if they have no scoliosis and no asymmetry. But are they like that all day? Are they seriously straight in that wheelchair from the morning until the evening? Do they not, at least when they get tired, go to one side? Does their head not fall to one side when they are tired? We need to think about the child all day, not just for short periods. There are 2 situations where we use the jacket if the child is straight. The first one is if they are straight and weak, so that they can sit, but they cannot sit for long, or they are able to have good head control, but can only sit for more than about 10 or 15 minutes with a jacket to support them. Because wearing a jacket not only helps the spine, but it allows the head to have better control because the spine is not moving all the time, and it can help the arms because when the trunk is stable in the jacket, then the arms may be able to work more effectively when on a table or in front of them. We can also use the jacket to prevent, and it may be that when the child is very active in the morning, that the jacket is not on, but when they are more tired and fatigued, then we will wear it to stop them then sitting in bad positions. Because sitting in a bad position, even when you have no scoliosis, can lead to scoliosis.
Спасибо большое. Вот похожие 2 вопроса. При подвывихах тазобедренного сустава нужно ли использовать шины или отводящие ортезы, или все-таки достаточно позиционирования? И второй вопрос. Можно ли сажать ребенка с вывихом бедер?
Firstly, I have never come across a child with a head dislocation. In 30 years, I have never ever seen a head dislocation. So my feeling would be that actually head dislocation, if it is truly dislocation, could even be fatal. So my feeling is if we are truly talking about head dislocation, where there are joints of the neck that are unstable, I would not be happy sitting a child without some support. I am really not sure that dislocation of the neck is an actual problem in many children with SMA. But if I was told a child had dislocation in the neck, I would have them in support for the neck. With dislocation of the hips, there is a big problem that we need to consider how far the child will progress. If a child is extremely weak, will never be a stander or an independent walker, are we going to put them through hip surgery? Is this viable when they are extremely weak, and is it useful? But what we also must consider is if we have a child with type 2 who will be much better when their hips are placed, then we need to think maybe this child would benefit from hip surgery or bracing. The fear of surgery is, if the surgery is done, it will make the hips around the pelvis weaker than before surgery. So we need to be aware that straight after surgery, the muscles will be weak from having been cut. We also need to think about making sure that the new position maintains mobility. So we can have hip surgery, but as physiotherapists, we need to be aware that bad positioning after surgery will still cause problems, and that the splinting after hip surgery may have to go on, particularly at night in bed or with standing, for even a year or more. So we need to think not only about what we are doing with the hips, such as splinting, but also what we are doing with surgery. One of the problems of splinting is that you take the splint away and you have not cured the problem. So we have to think, if we put a child into a hip splint for dislocation like a normal child, will it cure the problem? Only if the muscle has enough power to hold the leg into the joint. In the normal situation, when a baby is born with dislocated hips and they wear splints for 3 to 6 months, the muscles are normal. So we need to ensure when we put these hips in splints to try and correct the hip position, that we are actually building the muscle up as well to hold them there, or you take the splint off and the hips will fall out again because there is no muscle to help hold them in. So this is not just a case of sticking on a splint and hoping the problem will go away. This needs to be a combined effort by everybody.
Спасибо. И вопрос, как разогревать суставы, использовать горячую ванну, парафин или массаж перед растяжками?
You can use anything to warm muscle before stretching. Everybody should have warm joints before they stretch. We do not stretch before exercise. We warm before exercise. We can do massage, we can do heat, we can do a bath. This is why stretching in the bath or in hydrotherapy is very useful. But yes, you can warm them. You do not have to spend a lot of time warming the joint, even just moving it gently and passively to warm the joint up may be enough before you then start doing the active stretches.
Спасибо большое. Вот вопрос, который, мне кажется, мы не затрагивали сегодня еще, это усиление жевательных мышц. Как-то можно улучшить силу жевательных мышц? Если да, то каким образом, какие упражнения можно делать?
That is the work of a speech therapist. I do know that many children on Spinraza think their speech has improved. Many parents think they are louder and they can chew better, but this is not the realm of physiotherapy. This is the work of the speech therapist. And to answer this question, you really need to speak to a speech therapist.
Спасибо большое. Еще вопрос такой очень конкретный. Ребенку 10 лет, тип 3. Он теряет способность ходить. Есть сколиоз небольшой, контрактуры голеностопных суставов. В настоящее время ребенок получил 4 дозы спинразы. Как и что мы можем сделать, чтобы сохранить возможность ходить?
The first is to try and reduce the contractures, because a 10-year-old is about to grow and go through puberty. And this is a very, very difficult time for a child with SMA3. Now, the Spinraza will help. We know that. We have seen a child with type 3 who would have lost ambulation without it. But contractures will make the walking harder, particularly as they grow. So the first thing we would do in our unit is serially cast the feet from our very specific protocol to try and improve the foot posture. That is our first job. And that is like the pictures I showed of our young man with SMA3 who was walking on his toes. But there must be a commitment to maintain that movement. We must try and prevent hip flexion contractures, and we must try and keep the spine as mobile as possible. And we would do quite a lot of work over a therapy ball or a peanut to try and keep the spine stretched, strong, and mobile. We cannot, with growth, be sure they will not get a worse scoliosis, but many children with type 3 who are walking and have scoliosis can walk again after scoliosis surgery. So we have ambulant type 3s with scoliosis who can have spinal surgery and still walk. So having spinal surgery does not always stop them walking. But if they want to continue walking, they must stay strong around the pelvis, around the hips and legs, and keep the spine as mobile and stretched as possible through games and activity.
И вопрос от наших взрослых пациентов. Как подобрать нагрузку? Какую нагрузку взрослый пациент, сидячий, не ходячий, может и должен получать в неделю?
Every day, like everybody else, an ambulant type 3 should be doing some exercise every day, even if that involves walking at a faster pace than normal, if that involves doing some activity they do not usually do. You can use the elastic bands, you can use small weights, you can do yoga or Pilates, you can do sport. There are many things that you can do. You can do things for your shoulders and arms, such as baking or painting or playing a musical instrument. There are many, many things you can do, but 30 minutes of activity every day, more than you would normally do. If you are ambulant and you walk, just walking by itself is not aerobic exercise if it does not make you warmer, that you have not gone a little faster than normal. If you are just what we call strolling, going along slowly, taking things easy, this will not count as exercise. It must be aerobic. Even playing a musical instrument can be aerobic exercise. It makes you warmer, it makes your heart rate increase, it makes your respiratory rate increase. 30 minutes, it's not a lot in a day. It's probably only a quarter of the time, if not a lot less, than we spend on our phones, playing games, watching the television, on the Xbox, on an iPad, browsing the internet. You think, take 30 minutes of that away and make it into exercise. Plan a program that involves every part of the body. even if it's a different part every day. 30 minutes out of your electronic time is not a big price to pay.
Спасибо. И последние у меня два вопроса. Если есть физический терапевт, который не знаком с особенностями СМА, на какие ресурсы его можно направить для изучения особенностей физической терапии при спинальной мышечной атрофии?
One of the problems that I am not aware of is how many of the documents, this is a question for Olga herself, is how many of the documents are translated into Russian. There are standards of care, there are physiotherapy resources, there are exercise resources. I am sure that the SMA Association in Russia has information about what SMA looks like and the difficulties of the patients. If you do not know SMA, find a Russian physiotherapist who does know SMA. There are always people you can ask questions, so that the most important resource is your tongue. Ask, find, put in SMA. There are many documents in foreign languages, many SMA support groups around the world. SMA Europe, Treat SMA, Treat NMD. There are SMA groups in America. There is no lack of resources available. If you do not understand the exercises or the priorities of exercise, then you must find a physiotherapist experienced in SMA in Russia. And I know there are a couple, I have met them, so that they do exist. But ask. It is never a shame to ask. There are many things I don't know, like myofascial release, which I will now go and read about, but we only learn by asking and finding.
Спасибо. И последний вопрос про родителей. Имеет ли смысл родителям, которые вынуждены поднимать тяжелого ребенка с астма, надевать при этом какие-то мягкие корсеты, пояса, реклинаторы для поддержки и защиты своей спины?
For their parents themselves to wear spinal support. No, the best treatment for parents is to stop the heavy lifting. A spinal support will only do so much, and I can see Olga smiling, so I know that she does far too much lifting at home and is not looking after herself, but that is something I will discuss with her separately. But putting a spinal support or a jacket is only half the problem. That may protect your back or your low back, but actually the lifting and carrying is dangerous for both you and the child. So that if you really get a severe back problem, if you are a lone parent, or if your other partner or your grandparent cannot lift the child, and you really do get severe back injury, then nobody can lift the child. It is important to try and put measures in place, lifting measures, hoists, sliding boards, ways of doing sliding transfers to take the weight of the child. The child should never, over the age of 4 or 5, be carried up and down stairs. This is really a problem. Lifted in and out of a bath is a bad lift. Lifted in and out of the car is a bad lift. Lifting in and out of the wheelchair is hard for the spine. Now, many parents say to me, I have been doing this for years, I am fine. But they are not really fine. They have backache, they have neck ache, they have shoulder pain, they have pain at night in bed. And this really is not a way to live life as a parent. You cannot help your child when you are in pain. So we must take away the cause like we want to take away the cause of SMA. To take away the cause of the parent's pain is not putting on a splint, it is taking away the need to lift. And we need to find in every country, for every parent, simpler ways of moving a child than picking them up when they are heavy, when they are weak, when you are trying to lift a child who is on BiPAP, when you have machines to lift as well. We need to be supportive of each other in lots of countries. It's okay getting treatments, but we need more than treatments. We need support and we need help to manage every day that we are looking after these children and adults. And it is a whole life of support. It is not just about new treatments and new cures. It is about getting through every day without pain, with fun, with enjoyment, with quality of life. And looking after parents is a big part of quality of life.